you guys again. It's 3 o'clock on the dot, so we'll make sure we'll get you guys out on time. Anybody told you today that you were doing an awesome job? Because you are so close to the end. You guys literally, this time, May 1st, you're going to be completely done with phase 1. Do you realize that? You have less than a month to go with this. So you are so close to the end. Hang tight, push through. You're doing awesome. Okay. PEDS stuff. Let's just kind of refresh some of this. This is from the PEDS oncology lecture. So sad before we get to so happy. Which tumor type has osteoid substance associated with it? Osteosarcoma, yes. Contrast that to which tumor types have small round blue cell tumors? Rhabdomyosarcoma. And there's a second one. Ewing's. Yep, Ewing's sarcoma. So Ewing's sarcoma, rhabdomyosarcoma, small round blue cell tumors, osteoid substance, osteosarcomas. What are the compounds or the electrolytes that you need to be concerned with if you are concerned for tumor lysis syndrome? Potassium, high or low? High. Yep. So potassium's one. LDH, sure, yes, secondary. Uric acid, yep. And then what other electrolyte? Not calcium. Phosphate, yep. Phosphate, correct. What is the most common type of pediatric leukemia? ALL. Yep. What type of cancer has Reed-Sternberg cells associated with them? Hodgkin's. And if you had a teenager who was presenting with Hodgkin's, what might they present with, how might they clinically present? A lymphoma. How is that lymphoma going to present? Supraclavicular node. Yep. Or if there's acute respiratory distress. Yep. So respiratory distress very acutely, the supraclavicular node, or these B-type symptoms. What are B symptoms? Yep. Systemic symptoms, meaning the whole body is not like, hey, cancer. What tumor type has an abdominal mass in a toddler and hypertension? Wilms tumor. What kind of tumor is that? Embryologic origin. Which type? Nephroblastoma. Yep. And if you, at the primary care level, your family comes in and they are worried about lymphadenopathy in a child. What are the concerning characteristics of lymphadenopathy in children? How long? How big? When do you need to start thinking about that? Greater than 4 weeks. And then what size? 5 centimeters, that's too big. 2 centimeters, yep. When in doubt, PEDS, guess 2. Yep, 2 centimeters. Okay, awesome. Guys, this is our last week together, which makes me incredibly sad. Really, it makes me so sad because all of this girls' classes. But that means we have 3 lectures left. So we are getting through PEDS Endo. We will start PEDS surgery today, and then we have a combo of PEDS, emergency med, ortho, kind of just to wrap it all together. So that's where we're headed. But we're getting to jump back into my true dream of being a PEDS endocrinologist, so be excited with me. We were talking about diabetes. We were talking about how it really, the order of the polyphagia, polyuria, or polydipsia and then polyuria should be there, and what it's going to present like. So again, just kind of catch us up to speed. Oftentimes, kids will present with 1 of 2 variants. One will be abdominal pain. Another will be nighttime enuresis, or kind of a third is just an overall, this kid doesn't seem like themselves, weak, fatigue, malaise. Not what you would expect from this kid who's normally just go, 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 go this whole time. Unlikely you're probably going to see blurred vision as your first symptom. However, if you see that in a PANTS type question or a one of my type questions, that's trying to just like really throw you that bone. And then DKA. So that is where we picked off of talking about when we were talking about that diagnosis and then what happens when that primary presentation is DKA. So if we're looking at how are we diagnosing this kiddo that has diabetes, well certainly you can always do this with blood sugar. So you can have that fasting sample, a random sample, and then that glucose tolerance test. So a lot of different ways to get there. Also with your A1C, and my favorite lab, because it's that 3-month look, that open hemoglobin that attaches. So what percent of that 1% of open hemoglobin has a sugar attached to it, is what it's telling you. When you consult endo, a lot of times endo will say, yes, I would like you to get several different types of autoantibodies, and that's more at the endocrinology level to say which type we're differentiating of what different biologics might work for this child for a little while. So that's kind of in the endocrinology realm. So definitely something to talk to them about, but know that that will sometimes be asked of you if you're in an ER setting to be able to get some of those labs too. If one of the questions that will sometimes be asked is if a child comes in, they are diagnosed with a type 1 diabetes, the family is going to ask, does everybody need to get screened now? Do all the kids need to be screened if we have some genetic predisposition to something based on some of those autoantibodies? And the current recommendation right now is no. We are not screening all the other siblings in the family for that as a general rule of thumb. So just an answer for that. That might change over the course of while we're all providers together, but that is today's. So that takes us to that presenting symptom of DKA. And I had a residency proctor or residency director who always say, you need 3 things to have DKA. What are those 3 things you need for DKA? Diabetes. Yes, you have to have diabetes. You have to have what? Ketones. And then what's your third one? Acidosis. So what if you are a diabetic that has ketones? Everyone always in the ER is like, they're in DKA. Well, are they actually in DKA? Do they have the acidotic part, right? They might just have DK. That's okay. They can have DK. You have to have an acidotic child to have DKA. Otherwise, you just have DK. Or just D, right? You're just diabetic and you're sick that day. That is an option as well. Okay? So, for 3 things you need, DKA. Acidosis is very, very important with that. So certainly, especially for a child who lives in kind of this state all the time, where you're trying to keep them in a normal state so that they can grow and function, now you've introduced a disease process like diabetes. Now you introduce a second disease process where they're sick, they're stressed, there's acute illness, there's something else going on, and that pushes everything that we had in a nice normal state off the cliff, where oftentimes we get into DKA when you have a child who's acutely sick with something else. And it might not be something big, bad, whatever. They might have some enterovirus or adenovirus or something, and it's just enough that it pushes them over the edge into DKA. Oftentimes your presenting symptom is going to be some sort of that abdominal pain, some sort of GI something. My stomach hurts, I've thrown up a lot, I just feel nauseous, kind of anorexia, I don't want to eat. So things like that can certainly accentuate it. So if you have a diabetic kid who's having new GI symptoms, something to kind of keep in the top of your head. And then certainly if we're in a more advanced stage and you're having small respirations, you're having that fruity breath, you're having EKG changes, you know something else is significantly going on there. Altered mental status, you know you're significantly further down that path. So pay attention to these kids early, especially if they're known diabetic kids, because they will likely manifest with some sort of early GI. Please don't memorize this other than to know what normal body pH is. So if you know what a normal pH between 7.35 and 7.45 is, then you should be able to understand that if you get down into that acidotic range, once you hit, I am no longer normal, I am acidotic, now I have met that criteria for the A part of DKA. So I'm not going to try to pull out for your test, is this mild, moderate, or severe? Just to give you an indication of the level of acidosis is going to determine how severe a lot of these symptoms are. Your body's physiologic response to that acidosis is going to be this compensatory mechanism with the way they're breathing, with the way that their heart is manifesting, things like that. So the acidosis is going to determine really the severity of how sick they are. So it can look like a glucose of 250, could be 251, or you can have a glucose that's up in the 900s, the thousands. It could be anywhere in between. So That's one of the things when you get in the hospital, you'll start seeing is nurses will, or docs or anybody will start talking about how high a blood sugar have you seen? Well, I've seen a 936. Well, I saw a 1110 or whatever it is. To see how high these blood sugars were seen. Again, acidosis, then your bicarb, your CO2 is going to be very low, because that's one way that your body is trying to compensate, is to breathe off all that extra CO2, breathing off as much of the excess acid as possible. So for kids, all your DKAs are going to get admitted. Your textbook says there could be an inpatient versus ICU, but we'll tell you in real life, they're all going to go to the ICU. So every kid is going to go to the PICU for DKA management. The biggest thing you need to remember, if you think about their presenting symptoms with some GI things, is that most of the time, especially with their respiratory compensatory mechanisms, most of the time, the biggest thing that you need to correct is the functional dehydration that is going associated with this. So think about that for when we get into all the treatments, is if I know nothing else, I'm trying to fix that dehydration component first. The insulin then is needed to both fix your acidosis and your hyperglycemia. So you could run fluids all day long, you still will have nothing that's going to help that extracellular glucose get intracellular until you have insulin. So IV hydration and insulin are functional mainstay treatments of that. How that's given in pediatrics is very, very different. We will go over that. But functionally, from a physiologic standpoint, that's what I need you to remember. And then very careful monitoring of all of your electrolytes, because they are all over the place and they're wildly up and down and all around. And so management very closely with those is super, super important. Biggest thing is that you want to avoid these rapid shifts. So what happens if you're like, oh great, I know exactly what to do. My glucose is at 1,000, I know, I'll give insulin and I just drive that sucker all the way to the floor. What happens then? What happens if you have these rapid fluid or rapid shifts in your glucose? Yep, you have all of these osmol changes. You have this rapid expansion then, and you have cerebral edema. And think about how well cerebral edema goes in a developing and immature CNS process. Right? That's not great. So it's not great for anyone, cerebral edema, especially a forming brain. So cerebral edema is really what you're trying to avoid at all costs in these kids. So yes ma'am.
Sorry, man, can you just go back here? Is the 5-part? I just want to make sure, is it 20 or is it 18?
In kids, there's different protocols. So some hospitals are going to say when we're under 18. Really the definition should be when you're under 20. But I'm not going to ask you specific labs or, well, is it under 18 or this. I'll give you something that's super obvious of that. Like I'd give you like, it's 11 or 9, something like that. So this slide, highlight it, star it, underline it, bold it, whatever you do to let yourself know you need to know this one, okay? So you're out as a provider somewhere, doesn't matter where. You could be in the jungles of Africa, you could be downtown San Antonio, does not matter. If a child comes in, you have determined that they are diabetic, they have ketones, and they are acidotic. You need to do DKA management for this child. What you need to do very first is think, I need to fix their dehydration problem, the underlying problem of the dehydration component of this. That was first, so dehydration and insulin. So I need to give them a bolus of some sort of isotonic fluid. Okay? We learned from that last block, it's 20 milliliters per kilogram for most kids, unless they're neonates or unless they have heart issues. Okay? So that's where the 10 to 20 comes from, but for our purposes, most normal kids, you're going to give that 20 milliliter per kilogram bolus of this isotonic solution. Okay, that's number one. Okay, step one, we've done it. Check. Then you still need to give them more fluids. Remember, they're going to be breathing deeply. They're going to be continuing to have these fluid loss. They're likely significantly down, but you don't want to correct it too rapidly. So when we're looking at this, if you're saying the first half of the correction is going to happen over 12 to 24 hours, the rest over the next 24 to 36 hours, what is the minimum amount of time then it should take you, absolute bare minimum, that it should take you to correct their fluid status? 36 hours, right? So if you see something or somebody in an ER, in an ICU is like, we can get this kid corrected in 12 hours, you should pucker, okay? Because the minimum amount of time to avoid cerebral edema is about 36 hours, right? Ideally, you're in that 48-hour plus range. Don't go more than 36. Don't go shorter than that, right? So just thinking, I need to replace the fluids, but I need to do it slowly. So the first half, those first day or so, the second half is going to happen over the second into the third day. Then at some point, you're going to say, wow, I have this compensatory sodium response, if you remember that from endo, where my sodium is way too high for this kid. So I'm going to do half normal saline, half the amount of salt, but I do need to add potassium in, and I do need to add that glucose in, because if I'm giving them insulin on opposed to glucose, now I'm going to just make them hypoglycemic. So that's that second half. And you are not, this child is not taking any oral intake whatsoever. You are controlling for any glucose that is going in and calculating that with an IV. So they are NPO this entire time. So that's our fluid management. So that was step one of what am I doing with their fluids? A bolus at first, running it slowly over time, and then adding potassium and glucose in with less sodium in that third part. What am I doing with my insulin then? Well, my insulin is going to not be bolused. So star it, highlight it, underline it, send it home, whatever you need to do. That is a huge difference in the world of PEDS endo and adult endo. You never bolus insulin on a child. Never, never, don't do it. Don't think about doing it. Don't look at doing it. Don't be around somebody who's going to bolus insulin on a child. Like, if that comes up somewhere, you kick that in the shins and you say, no, we're not doing that. We do not bolus children with insulin. Okay? Don't know, like somebody picks this answer on every test, every semester. I'm like, do not pick it. Just don't pick that answer. It's wrong. I'm telling you right now, it's wrong. Okay? So what are you going to do? You're going to do a continuous infusion, and this is going to help take that extracellular glucose and give it that channel to be intracellular. You've learned that physiology over and over. Do not bolus it, right? It's going to do that. That's going to shift it way too fast. You're going to get cerebral edema in this child. And then that third step kind of goes with that fluid management is you have to give them some glucose. You have to get their physiology back to a normal state. So at some point, you're going to add those dextrose fluids back in, right? So you don't want to add it too early because you need to correct the acidosis. You need to correct for what's there, but you need to at some point make sure that you're balancing between the fluids, the dextrose, and the insulin. So you're adding it in. So if you hear in the hospital that it got wide in, it's truly because there's a bag of fluid running with a wire or with a tube, and they put another bag of fluid and they connect it with a Y. So the fluid, the tubes are wide together. It took me forever to realize what Ying in fluid was. And I was like, oh, it's like B symptoms. Like anything there's like there's a letter, I just seem to have trouble. That's what it means. So when you're below about 200, you really want to make sure that you're avoiding hypoglycemia. So you're Ying in a higher amount of dextrose to make sure that you're balancing this out. So you're not going to be responsible for it on your own, but if you're somewhere and you're like, what do I do? What did Klein say? Give them fluids, give it slow, make sure I do not bolus insulin. If you have that, you will be okay. That's fine. Most serious complication again is going to be cerebral edema. So we again do not want to have these rapid shifts in fluid or rapid shifts in our glucose level. Really more if you're like, what's the cutoff? How do I know if it's too fast? Well, I don't want to go more than about 100 ever in an hour. So even if I'm at 1,000, I don't want to go to 800 right away. I still want to go about less than 100 so that I'm not doing more than 100 an hour. Want to make sure again that you're accounting for all of your other electrolytes there. Your baseline acidosis treatment is being treated and looked at. Things that we also do not do in PEDS. We do not treat with bicarb. So just take that out of your treatment protocol for kids with this. We're not going to bolus bicarb ever. We're not going to be bolusing much of anything other than that initial fluid resuscitation. And as a reminder, if you're thinking, oh no, maybe a colleague, maybe somebody else, maybe somehow it got bolus, or just throwing things, maybe that happens. See, this is how I feel about bolus insulin. I just start throwing things. But if you're thinking, well, that happened, what am I on the lookout for? I'm looking for those signs of increased intracranial pressure because of that significant edema. So were they with it and now they're not? So I have a change in my consciousness. Was there something that's kind of popping out? I have new papillary edema, I have this new pressure, I have a new headache. I have something that's showing that there's more pressure. And how am I going to treat that? Well, I need to give more osmols. So I either need to give mannitol, it's really high in that, or hypertonic saline. Do you know how hypertonic is? 3%, yep. So hypertonic is 3% saline compared to what is normal saline? 0.9, yes, perfect. So then what are our goals with these type 1 diabetic kiddos? Well, we want to make sure that just like anybody with diabetes, that they maintain a normal range. However, again, you have this developing brain in a child. This child's brain is so precious, developing, and we do not want them ever to go hypoglycemic. I would much rather have a child have excess glucose than I would ever want them to go low. So your goal with that is, and to communicate to families, is to not let these kids go hypoglycemic. Certainly you want to make sure that all of their symptom management is under control. So if they're presenting symptoms for this new nocturnal enuresis, we don't want them wetting the bed forever, so getting those symptoms under control. Yes, I don't want them to go low, but I don't want them to go high, be in DKA all the time either. And then I still want them to be normal kids. So I want normal growth as much as possible, normal development, normal things that are going on. And then remembering that this is going to be a big lifestyle change to these kids and to the family. So in residency, they had us wear the glucose pumps. I think I told you guys that, for a week at a time. And man, after a week of calculating my blood sugars every single time and carb counting and adjusting for my fake insulin and my pump, after a week I was like, I don't want to be diabetic, right? So now multiply that with a child who doesn't want to be poked and doesn't want to have that either, and you multiply that in a family who's trying to do all the normal things of life, plus do that for every single thing that those kids intake. So you're putting those glasses on to see those families can be make a lot of sense. So if you're seeing your adult patients and you're thinking, what do you mean you're stressed about this? When my kid's diabetic, every single thing that goes in that kid's mouth has to be accounted for. So just think about that when thinking about your patients and what's going on with them. Part of that is then going to be your management is with the dietitian to make sure that they are getting all those components of what they need to optimally grow. Certainly fiber is part of that. And then a big component of this is education for these families. One of the things that we encourage for anybody, for any of your patients, adult, child, whoever, but one of the biggest things that they can do to help themselves out is exercise. Exercise on its own takes all of these cells at an individual level and makes them more sensitized to insulin. So if you had a lazy couch potato cell, it might be going to take up to 5% more insulin to get that same glucose extracellular to intracellular. Then if you exercise, that cell is just feeling peppy, yes, has some cellular endorphins. I know that's not part of your physiology class. Think about that. Has some sort of sensitized sensitivity to be able to use less insulin to get that glucose in. So over time, they're having to have less endogenous or exogenous insulin. They just do better overall with exercise. So encouraging that for both your adult patients and your pediatric patients would be super, super helpful. And that just helps everything. Exercise makes everybody do so much better. This is what I just said, making sure we avoid hypoglycemia pretty much at all costs. And so this is a big mindset that is very, very different from kids to adults. So in adults, they want really, really tight control because you have this, you're trying to prevent all those secondary adverse effects, right? We talked about those. Where do the adults see those adverse effects? Eyes, kidneys, heart, peripheral nerves. Yep, so you see all that. That's all still relevant to pediatrics, completely relevant to pediatrics. However, my bigger concern is their developing brain, right? So brain is first, all those other things are secondary. So we're avoiding the lows and then still thinking about what are those long-term things. So what I want you to take away from this is don't spend your time memorizing if they're this age and they're this age. My point is that we keep them higher than we do adults. because the younger you are, I would rather you stay, if you're under 6, I'd rather you stay up at an A1C of like 8.5% rather than go low. Okay? That's what I need you to take away from that. So what their age is, so the younger you are, the higher your goal glucose is to prevent going low. Remember, if you do go low, because they are going to go low, every type 1 diabetic does, that those symptoms look very similar to going high or to DKA. So that is why it is always appropriate, when in doubt, nobody in a hospital, in an outpatient clinic, in a lab, no lawyer is ever going to fault you for checking your glucose. So if you don't have any other idea what to do for a patient, you could probably say check a glucose and you're going to be right a majority of the time. Right? Maybe not, well, maybe even on like a psych ward, but you could give it a shot. Your treatment, obviously, if they're with it and conscious, you can always give that PO. So kind of having something in your clinic can be really helpful. I learned this, one of the places that they had sugar-free candy, that does not help with your diabetics. Okay, so if you have something in the office, if somebody is going low, make sure that it actually can accomplish what you're trained to accomplish. Certainly if they're not with it, you're going to make sure that you are giving glucagon. Is anyone given glucagon here? Forces gluconeogenesis. Anyone given glucagon? Do you know what happens if you give glucagon? Yes, they're going to throw up. They will throw up. So just, if you push glucagon, be prepared for them to throw up. And then IV glucose, certainly if you have an IV or an IO, you can always give that. A lot of kids are not going to realize that they're low. This is one of the other reasons too that if you have a diabetic, be thinking really carefully if you want to give a beta blocker, because a beta, your beta adrenergic cells, your beta adrenergic response is going to be a lot of those things that warn you for these things. And so if you have a beta blocker, you don't get those warnings. So just something to keep in mind. If I had to choose between X and Y medication and I have a diabetic, something to think about. So we already talked about that. Yes, you want to think about the eyes. So retinopathy is going to be something that you think about. Certainly a couple years later. These kids, especially for these young guys, they're not going to have retinopathy overnight, but they do need to be getting in the pattern of regularly seeing an ophthalmologist because they're at a higher propensity to have eye problems. Same for nephropathy. So a annual UA to assess for microalbumin, if they're spilling albumin. They're spilling that to see if they're having renal dysfunction and spilling protein. And then coronary artery disease, so your annual cholesterol that they will get. If they didn't have diabetes, when would we get that cholesterol check? 9 to 11, and when's your second time? 17 to 21. Yep. So this though, if they do have diabetes, they are getting it annually. And then neuropathy, so same with the foot checks that you would do at any time. For these kids, type 1 is juvenile diabetes type. A lot of times there's that genetic component, that autoimmune component. And so when you have one autoimmune disease, you're at a higher risk of having a second autoimmune disease. So one of the things that we constantly look for is, are you at a propensity to have a second autoimmune disease? So common things being common, you're thinking hypothyroidism, we'll talk about here in a little bit, celiac disease, you have the IgA deficiency, or certain, the more rare one, Addison's disease. But you're looking at what other autoimmune things could be attacking this child and screening for those while you're getting your annual workup. So this one I will need you guys to know. So this is a look at what are the things that I am getting. So it's the ones that we already just talked about, right? If I have a child, I'm making sure they're not going low, and then I'm making sure that I'm checking for all those other things that could go wrong. The eyes, the feet, or the peripheral nerves, your kidneys, high blood pressure, dyslipidemia. When am I checking for those? And am I doing it at a goal? Because this is what you're going to be in charge of. Right? These are the things. The endocrinologist is going to deal with their insulin and their A1C and all of that management. This is a primary care PA. This kid has diabetes. This teenager has diabetes. This young adult has diabetes. Do I make sure that I have scanned them? We've screened them for thyroid issues, celiac issues. Have I tested their urine to see if they're spilling protein? Have I made sure that they are seeing an eye doctor for an annual ophthalmologic examination, things like that? Okay. The more familiar you are with it now, the better off we're gonna be. Little other things to consider, like I just said, there's a big psychological component to this. This changes a child and a family's life forever, so being aware of that. A lot of times there can be a big source of grief associated with this. This really wasn't what people had in their bingo card for how they thought life was going to go. And so there could be a significant grief aspect of that. So having any kind of behavioral, both peds and then for adults on that. Some of their non-adherence and some of the cognitive functioning that we talked about from block 1, right? You have this functional, brand new kind of physiologic adult as a teenager without the cognitive or that frontal development, right? So you get a lot of teenagers that will say, I just don't want to be diabetic anymore. And they will just stop taking their insulin, right? Well, that's going to land them in the ER every single time for DKA. And at that point, you're 14, 15, 17, whatever, you don't really care, right? So something to think about for there. A lot of times they are fearful of needles if they're younger, or they just don't want to test anymore because their fingers have been pricked 4 to 5 times a day for a decade plus at that time. And then eating disorders, a secondary complication to think about. Think about if you were 2 or 3 and you developed type 1 diabetes. Well, now you've spent an entire lifetime counting every single thing that went into your mouth and adjusting for that. It puts in a hyper emphasis on food. So that could be something to be aware of as a secondary complication when you get into these adolescent years. Things to think about for your sick day rules. So we already talked about being sick is going to make you more likely to have things like DKA and some of these other complications. So what are you going to do as that primary care PA about this? Well, somebody comes into your office or to the ER. One of the things to look at is, well, first off, I know they're diabetic, so that takes care of the diabetic part of DKA. Now let's look at the K part. Do they have these ketones? Checking for ketones to see if they have that. Then we get into that, oh, are they acidotic, which gets into our management of that fluids and insulin. If they do, we need to end up obviously in that DKA management from our acute care, all that stuff we talked about with that DKA management, your insulin management and your fluids. Right? So that's the same stuff. Your sick day management, if you can do it outside, so if you're diabetic and you don't have ketones yet, or you have slight ketones, then this is, hey, we need to give more insulin at home, keep them hydrated, see if we can keep them out of the ER. So that's something to ask of people, especially families with kids, when they get to the ER is, has your endocrinologist given you a sick day plan? Right? A lot of them, they'll forget to tell you and then they'll pull it out and you'll be like, oh, so this is exactly what we're going to do today? Got it, good. Something to ask. All things DKA. I love typing. It's just fascinating. Not as fascinating as the thyroid. Love me some thyroid, right? We've talked about this so many times in block 1, block 2, block 3. It's on the differential for absolutely everything. That it could be a thyroid issue. Now we're going to talk about why. Why is thyroid such a hot topic in the kids' world? Right? As a reminder from Endo, way back in, is it sophomore semester? It's junior? Okay, well then it's not way back. Well, let's pull from that again. Remember, you have your TSH for T4. In kids, those marry together. You don't get one without the other. Unless you have adult physiology, which really at that point, you're no longer peds, right? Menses, you're completely SMR5 kiddo, you're off, really not in pediatrics anymore. You have not proved that all of the brain and all of the secondary organ works as well. So they are married together. You get TSH and free T4 together. The other thing that you would be responsible for at a primary care PA level is going to be for a thyroid ultrasound. So that would be part of your workup. Remember, if we're thinking about what's in our realm versus what's not in our realm, and a good example is an echo is not in the primary care PA realm. A thyroid ultrasound is. So just to give an example. So for the thyroid ultrasound, you are trying to differentiate, do I have a solid or a cystic lesion if I'm feeling a nodule on physical exam? Because the high rate of malignancy in children. So that is the reason that the ultrasound is such something that you would be responsible for, because of the high likelihood of that transformation. So I have some symptom where a thyroid is on the differential. I have gotten labs that have a TSH and a free T4. I know that something is wrong there, and or I can feel something on exam. Your last step then again would be thyroid ultrasound. And that's functionally where you are going to stop. And then past that is more of a referral to say, okay, well, who do I need to send to endocrinology? Well, anyone who had these abnormal thyroid labs, anyone who had an abnormal thyroid ultrasound, anyone who has something outside that normal realm that when we talk about this that I'm not going to be able to manage. So if you're thinking I'm going to do this iodine therapy and I'm going to get a biopsy of this or that, nope, you're going to get labs, ultrasounds, and then ship them off to PEDS Endo. Can there be an entity where a child is born with hypothyroid? Based on this title slide, the answer is yes. So something to think about is, again, you have those two parts. What's going on with the brain? What's going on with the organ? So we're talking about the organ in this case for primary. So something happened with the thyroid organ itself. Did it not form? Did it not form correct? Does it not work? Is it in an ectopic place where it cannot circulate thyroid hormone? So that could be one of the thousands of different causes. How would I be checking to see if this has, if somebody has this? 1 in 2,000, pretty rare. But how am I going to check that? Not necessarily an ultrasound. We can get there. What do we check on? All babies at 24 hours of life. No, we're not going to get a TSH. What else do we get? Remember, way back in block 1. What did we get at 24 hours of life? A newborn screen. Yep. So this is going to be on your newborn screen. Okay. So congenital hypothyroid is one of the things that we check for. The other thing then, secondary, could be wrong. You could have something that developed wrong in the HPA axis, or something wrong in the brain. So the thyroid gland itself is fine. It's just waiting for some sort of signal that it never gets. So that'd be a secondary cause, something's going on. Or you have something secondary where you don't get that cross-placental transfer from mom. So something happens where mom does not transfer over to the baby, so the baby is functionally hypothyroid. You can have mom's autoantibodies that will cross and go attack baby. Certain medications can go over and attack baby. The inborn error of metabolism can attack itself. So there's a whole bunch of different causes. Point being, the child can come out for a number of reasons and be congenitally hypothyroid. So what are we looking at then? If you are saying, today I am on the nursery ward, I'm going to go examine all the babies, what am I looking for? So the things that you would be looking for that are particular for this, because we looked at a lot of other things that could be sepsis related or respiratory related or all of these other different systems. What is specific then to congenital hypothyroidism? It's a little bit different on here. Well, one of the things is a particularly large tongue. A big, big tongue. What was the other thing that we saw that had a large tongue? Down syndrome, yeah. And really in that, the tongue is normal, the head is really small. In this, the head is normal, and truly the tongue is too big. So a large tongue is one of the things. The other one is a large fontanelle. So more than 5 centimeters in that fontanelle, right? We had a soft spot. We didn't say soft Grand Canyon, right? We said soft spot. So it's about a finger breadth in the front and in the back. If all of a sudden you're putting 3, 4 fingers to be able to, like, this is 5 centimeters. Like, you feel like you're on your OB rotation where you're like, how dilated is the cervix? But if now it's on the baby's head, that's too wide. Okay, so a large anterior fontanelle, large posterior fontanelle concerning congenital hypothyroid. The rest of it, we've talked about some of that. So you would pick up on that dry skin, constipation, lethargic feeling, and then some of the other ones that go with all things in babies. So this baby, if you saw respiratory distress, hypothermia, poor feeding, distension, right? You would think, my goodness, maybe they're septic, maybe they have neonatal meningitis, pulling from those other things. Maybe they have a neonatal pneumonia, but congenital hypothyroid, some of those other things, would put that higher on your differential. A lot of times it's real subtle though, so it doesn't happen for several weeks, maybe weeks to months before it is actually evident. And that is why one of those things that's so important to, number one, get the newborn screen, and then number two, follow up on the newborn screen. So that would be one of the things on your well visits. Does this baby, they get the newborn screen or they don't? Again, a reminder, for that, you would have a high TSH in the classic form of the congenital hypothyroidism. The brain is saying, hey, 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 and trying to stimulate, so the TSH is high. And the gland itself has a low free T4. And we're treating with that same oral levothyroxine or oral Synthroid that you would for anybody else who is hypothyroid. You would initiate that ASAP. How do you give that? Remember how you give hypothyroid medication? What do you give thyroid medication? Oral. Yep. Yeah, you can crush it up and you give it with a dropper, but like, do you want to do it like with feeds, without feeds? What do you want to avoid? Without feeds. Ideally, how long?
2 hours.
At least 30 minutes. Ideally, up to 2 hours. But wait, we said the babies need to feed every 2 to 3 hours. Yeah. So ideally, you're giving about an hour before a feed, and then you're trying to avoid it with milk. You're trying to avoid this with feeds. So it's hard in babies. Is the most important. Yes, ma'am.
So with babies, do you increase hospital dose of chemo anticipating rapid
Not necessarily. So you start with 50 micrograms for all babies, and then you adjust it from there. So that first dose is just 50 micrograms off the bat. Try to do it an hour before feeds, and then you check every couple of weeks to see where you need to adjust. Okay, so talking about the specific types then of Hashimoto's and some of the differences between adults and pediatrics, right? Not to repeat this from last semester. How is this going to present differently in a developing child? One of those things is that you don't see is linear growth. So that should be something that you're picking up on. You're like, this child is growing in brain, in the head. The head is growing, the body is growing, but they're not getting taller. That should be a red flag. Something's going on with hypothyroid. Certainly the rest of these should look familiar. So your cold intolerance, your energy, your brittle skin, brittle nails, all those things, that's the same. The linear height difference is one, and your delay in puberty is the second one, that are very specific to pediatric presentation. It is different from those adults. In high TSH, so it's being bombarded, it's bombarding the organ, low free T4, and they will also have the same antibodies that the adults do, so your TPO and your TG, so those will give you that definitive diagnosis again. And then that's where you say, okay, you got it endocrinology, make sure you do a warm handoff, and they will take it from there for the PEDS Endo world. That's the difference then between adults and kids. You guys are going to see hypothyroid and Hashimoto's on a day that ends in Y, right? So you guys at that primary care level in the adult world are going to manage that. This is one that's managed at PEDS Endo to account for all of their different growth and puberty stages. You might be refilling it, but they are going to manage it, okay? So that's a big difference there as well. Remembering that if you get something where they have a euthyroid patient who has antibodies, that you're going to check very frequently for these patients because you know at some point the organ won't be able to keep up, but you need to know when that tipping point is. You're checking pretty frequently. And then here's one last difference. If they have a Hashimoto's patient that is hyperthyroid, we do not ever treat them with PTU. So that is not something that we do in kids. No PTU. Symptomatic kids are treated with methimazole and propranolol for symptoms. So that's one thing that always trips me up on my boards. Propranolol was an answer, but propranolol treats the symptoms of that hyperthyroidism, excuse me. Propranolol treats the symptoms. It does nothing for your underlying etiology. Okay? So it's like functionally treating a fever with Tylenol. You treated the symptoms, but you didn't treat the underlying virus, much like propranolol to methimazole. Graves' disease, the exact opposite. Hyperthyroidism that we were just talking about. A lot of females in this, so adolescent females. The ways that I have seen this present, a couple of times, right? We see only 5% of patients with hyperthyroidism are teenagers or pediatric patients. The ones that I have seen have all been adolescent females, and they present and they come over and over and over, and somebody keeps thinking that they have ADHD or that they are anxious. And so they get treated with ADHD meds and SSRIs. And how do you think Graves' disease plus Adderall does? Really, really bad. And then we're like, well, let's try to switch it to Ritalin. It's just as bad, right? Because you're treating something with a stimulant when they're already like in go mode, right? So something to think about is usually why for new anxiety out of nowhere or for new ADHD symptoms in a teenager, a go-to is to always check the thyroid. Endocrinology will manage this again, same thing, methimazole and propranolol. As a reminder, most of these symptoms are very, very similar other than the ones that we talked about. So if you remember that from your junior semester, you should be able to remember that. The exophthalmos is still the same. That eyes are truly coming out of the head there. The feeling of going, the tachycardia, all of those things, very, very similar. Weight loss. So see, weight loss, that would be another one, but very similar to the adult ones. Few things on inborn errors of metabolism. So I think that this stuff is super fascinating. However, I didn't feel like some of them, so this whole list, I didn't feel like that this whole list was maybe super applicable. So if you want to nerd out with me and you want to sit there and talk about maple syrup, urine disease, or tyrosinemia, or homocystinuria, I will do that all day long, happily. For the rest that maybe don't care as much as I do about that, we'll just talk about lactosemia and PKD. Don't everyone cry at once. We're getting close. I see your face. We're getting close. Let's talk about this. So inborn errors of metabolism, still pretty rare, right? Less than 1 in 100,000, yet these are ones that we do newborn screening for. Because even though they're super, super rare, there's a lot of things that we can do about this to prevent really, really bad outcomes. And functionally, that's why we're checking for these. So anybody that is going to come back with this, has anyone ever gotten a newborn screening for their kid, for them? Anybody had to go get it done? Just yet? Well, this is probably good. Everyone's had normal, their children have had normal newborn screens. So as a provider, so this is what will happen. You send it out, the kids come back, and you get something abnormal back. And then you're like, so you're thinking as this provider now, you're like, what do I do with this? Great, they've thought of that. So the newborn screen will come with something called an ACT sheet, ACT, and that ACT sheet will literally tell you what to do. So in the example of congenital hypothyroidism, it wouldn't just be like, this is abnormal, good luck, right? You wouldn't just call the family and be like, oh, I think you have congenital hypothyroid. It would tell you ACT, repeat TSH, repeat T4, repeat T3, consult endocrine, it'll tell you exactly what to do, and repeat newborn screen, whatever it is. This will tell you exactly what to do for all of these. So if you ever get something back, or you're covering for something, and you get that back, ask where the ACT sheet is so you know what to do. So likely you will need some genetic counseling. So all of the reason that we're going to talk about this, and these particular ones, is that you have this metabolic disorder, and it's eventually, because it's the metabolism part, it's going to end up messing with your pH of some sorts, and eventually you're going to end up with something that happens with the urea cycle, which Major Castellan would be so proud that you're thinking about that again. Something with your amino acids, or something with your organic acids. So something's going to eventually happen with one of those, and it's going to end up messing up. The specifics of this, please don't spend any time on this chart, but it's just to show you where inborn errors of metabolism are going to functionally align into one of those three camps. And before we go into that, let's take a break. So let's come back on the top. Yay! Okay, we got it. We can do this. Last hour. So, inborn errors of metabolism. Something has gone awry. So the one that we are going to talk about, really, in the cool history of medicine, the reason that we started doing newborn screens was for phenylketonuria, PKU. So what is happening with PKU? So you'll also hear that sometimes. People will say, we're going to get the PKU, and they're using that synonymously with newborn screen. It's not called a PKU, that is a disease. It's like when people call TMJ, and you're like, that's a joint. That's not a disease. I digress. Wow, that was really unintentional. So anyway, they're going to do these newborn screens. They're coming back. What is PKU? So PKU means that you do not have the enzyme that is able to take phenylalanine and break it down into an amino acid of tyrosine. So phenylalanine just backs up and accumulates, which is okay until it's not okay. And then when it's not okay, it can be very, very harmful to the brain. Thus, if you have untreated PKU, you will end up with a profoundly intellectually disabled child over time. So is this child born normal or abnormal? Born normal, and then over time, untreated, becomes abnormal based on that backup and that excess of phenylalanine. So how do you treat this? Avoid it. Avoid phenylalanine. Well, how do you do that in a baby? I'm so glad you asked. Super cool. They make a low phenylalanine formula. So the formula that you give this baby has low amounts of phenylalanine. It's really cool because you literally write a prescription for this type of formula and TRICARE covers it. So it's kind of cool. And the moms will often say, well, can we still breastfeed? And yes, they can work with a dietitian to figure out how much breast milk with how much formula is needed to have this low phenylalanine diet. Moms can have this as well, so if you have a mother who has PKU, she will need to have some phenylalanine during pregnancy for the baby to make sure that the fetus grows appropriately without harming her. So a very, very delicate balance there that you will end up having. So that is one that I want you to know, PKU. What's the other one? Galactosemia. So this is another one from block 1 when we originally talked about it. So in this, do you remember what the chemical composition of lactose is? What is lactose made up of? Glucose and galactose, right? So functionally, any lactose-based formula, if you have galactosemia, you cannot give this baby because anything that has lactose is going to break down into glucose and galactose, and now you have a baby that can't break down that galactose. And that is your problem here. This is then why, if you feed a neonate any type of lactose-containing milk, they are going to end up eventually with liver failure and renal tubular necrosis because of they cannot handle the galactosemia. So it's just going to end up continuing to back up. This is again one that you will see very, very quickly. So newborn screen has this on there, and this is one of those just board testable things. If you see a baby that comes in within that first week of life with E. coli sepsis, particularly from the urine, you should think galactosemia for your board exam. So that's just how they test it. And this is the one true indication for a soy-based formula. So if families want to do all kinds of soy for this or that, or my baby's less gassy for that, or the baby milk protein allergy, we already talked about how those cross-react, sure. Do that all day tomorrow. It's totally fine. The true medical indication of I need to avoid all lactose formulas would be galactosemia. So then those babies you give soy. And that's it. So we can talk more about all the other syndromes together. But on to the adrenal gland. So the adrenal, same thing. You can have your primary adrenal. So primary meaning the organ itself. And the secondary means something else is going on that is affecting that. So for your primary, this is just more of a board type question. Because ACTH is from the pituitary, ACTH is going to stimulate your adrenal glands. What else does ACTH work on? Melanocytes, yep. So if you get something on your boards that's like, this one 8-year-old child, the rest of the family is very, very light-skinned, and this one child is very tan. They're trying to tell you that there is an adrenal insufficiency. Secondary can come from your HP axis, something up top, often in the brain. Most often is going to be a craniopharyngioma, it's a pituitary tumor. Super interesting embryologic origins. The craniopharyngioma is embedded into the pituitary cells, so if you have adenomas, Those live on top of the pituitary. Craniopharyngiomas are embedded cell to cell. So very difficult tumor type to have. That can be a secondary cause of that. This one, in that case, there is not excess amounts of ACTH, so they have this adrenal dysfunction without being sertrained. Things to think about, other reasons that you could have that primary organ dysfunction. So is this an example of a child abuse case where they had an adrenal hemorrhage? Certainly things could be that. Is it medications? They're quite rare, so this medication as a primary cause is very, very rare, just given the fact that we don't use a whole lot of things like phenobarbital for kids. Certain infections, so meningococcemia can cause really anything. It can cause a hemorrhage anywhere or that ischemia anywhere, so that could be a place that you see this. And then the adrenals are one place where it's an infiltrative process, so if you really have any of your infiltrating diseases, sarcoid, hemochromatosis, amyloid, any of those, the adrenal glands can be one place that you do see that. So for Addison's disease, is ACTH high or low? High, yep. Is your cortisol low or high? Low, correct. Who has famously had Addison's disease? JFK, yep. So one that we always talk about. So you have this destruction of your adrenal cortex. Do you remember way back from probably freshman semester of anatomy physiology, what those different levels of the adrenal glands were? So that on the outside, what's that responsible for? So the way I classically learned it was salt, sugar, sex. So you have your salt things on the outside, having to do with aldosterone, sugars, your cortisol in the middle, and the inside are your sex hormones. So salt, sugar, sex. For those, for this, for Addison's disease, you have issues with your salt and your sugar. So you have glucocorticoids that are missing and mineralocorticoids that are missing. So anything that has to do with the hyperpigmentation from your ACTH, and anything that has to do with your salt craving, hypoglycemia, hypotension, weakness, are from your salt and sugar levels. You guys already said it, ACTH high, cortisol low, and then because your cortisol is low, other things are secondary to that. So yes, you have hyponatremia, yes, you have hyperkalemia, but all of those are because your cortisol and your aldosterone, or your cortisol and mineralocorticoids, the fludrocortisone are low. So when you're treating this, so endo is treating this, and you are giving a couple of different things. So your hydrocortisone is what you're giving primarily. So this is the closest one to be able to mimic what your body is doing. So it's a quick release, it's not a long-acting one, so it's about its clearance in 8 to 12 hours. So this is one that a lot of times for kids, they're doing twice-a-day dosing to have that morning dose of hydrocortisone and then that afternoon or evening dose of it. Second, they're giving the fludrocortisone. So that's helping with all of those electrolyte replacements, so that salt and sugar levels. Second one that you're talking about in that primary adrenal insufficiency is if you had a congenital adrenal hyperplasia. So sounds backwards, so it sounds like hyperplasia, but you have hyperplasia and hypofunctioning of some of them. So you have it it's kind of a misnomer there because it's getting bombarded with signals and it's getting bombarded with a backup, but its primary function is not working correctly. So in this one, you're missing that enzyme that's going to convert everything down into some of your other levels. And so everything is getting shunted down into salt, sugar, sex. So it's all getting shunted down into that androgen level of your adrenal glands. So for little boys, you don't notice anything. It's all making androgens. We are going down into that salt, sugar, sex realm. So all of those androgens, little boys, we have no problem until we have a problem with our salt waste. Little girls, what happens with little girls? There's virilization because everything is shunting into that androgen system. So this one, which one in the newborn nursery can you tell is having a problem? Little girls. Yep, so little girls, you are going to often get to endocrinology right away because you can see them on phenotype, you can see them on exam. Little boys, you're going to either have two scenarios. One, You have the newborn screen that comes back and flags you for a 21-OH deficiency. Or number 2, they get very, very sick and they come in hypotense salt wasting. And then you realize that they are very, very sick and have a primary adrenal issue. Last thing that we're going to kind of talk about here is Cushing. So exactly opposite. So now you have too much cortisol. So something is either exogenous and your body is making too much, or you are taking too much cortisol. So if you have a tumor, microadenoma for example, that is secreting ACTH, that go button is just on all the time. So it is just telling those adrenals make more, making a ton of exogenous amounts. Anything that's going to cause the ACTH to be on certainly can do that. And then all those same things that you see in the adult world are things that you are going to see here as well. So that should not look any different except for that same one in pediatrics as your linear or your longitudinal growth. So that should be a marker that something endocrinology-wise is off if they are not growing linearly. That should be your big thing there. Your 24-hour fasting, or 24-hour urine cortisol level, is that in Cushing's going to be high or low? High. Good. And endo will help distinguish between your dexamethasone suppression test. So if you're doing high dose or low dose, does that pulsatile amount shut that system off, or does it keep going regardless? So that's an endocrinology test that they're going to be doing. So certainly if it is something inside the child, so you're going to make sure that you're removing that, if it's some type of tumor, or stopping that, if you have something going on in your HPA. If it is exogenous, something to be aware of. If you have a kid that's on lifelong steroids for XYZ, for lungs, for autoimmune, or something else, something that you're going to have to manage and balance that. Oh my goodness, that means we are down to 2 lectures. The final